there's always so much to talk about in this lecture that I've gotten in the habit of just trying to cover one topic in some detail and maybe highlight a few other areas that we're trying to work on at our center. This first slide is a picture of what is it called? The Garden of the Gods in Colorado. And it's a beautiful area with all these nice little apices or vertices of rock formations. And we're going to be talking a lot about vertex today, so I thought it was kind of a nice slide to highlight. Just to begin, I wanted to mention that I don't have any financial interest in any of the companies developing products that we're talking about in the lecture today. However, we have been involved in some research projects, Dr. Cairns and I just outlined them below: PharmAxis, Inspire, and Gilead. I wanted to give special thanks to other members of our research team at Maine Medical Center. We have a robust research program at Maine Medical Center with people working on the pediatric side and on the adult side. I didn't actually put all the different members of our clinical care teams down today because this is largely going to focus on research developments. This is a slide that I put in many of my talks that shows the different approaches that we can take to treating the major problem in the CF airway, and that is that we have an abnormal protein, the CFTR, that's broken in CF that results in abnormal salt and water transport in the airway, mucus inspissation or clogging of the small airways, and subsequent infection and inflammation. And all this results in remodeling or scar tissue developing in the lung. And over the years, we've had a host of different ways of treating this, many of which have been quite successful and have resulted in some of the data that Hebe presented earlier today. We've been quite successful, but we're really looking for kind of a breakthrough type of therapy that will circumvent some of these downstream abnormalities that are shown on this slide. Next slide. That's not mine, is it? No. So here we see the therapeutic development pipeline, and as I showed you in the last slide, there are a whole range of different approaches that we can take to treatment of CF lung disease. And each of these different avenues of airway destruction can be addressed by different types of chemical approaches. And actually, I think we have the here. So we can start right at the beginning by looking at gene therapy, and gene therapy is still in its infancy, even though we've been looking at this for more than a decade now. We haven't really heard any new data coming out in the last few years. Some of the areas that are really exciting now, looking at restoration of airway surface fluid and in CFTR modulation. I'm going to focus today primarily on the Vertex story, which we'll get into in a lot more detail later. And then down below, there's still a lot of activity going on in anti-infective therapies. And at our center, we're going to be involved in two upcoming studies, one with MPEX, which is inhaled levofloxacin, and we're probably also going to be getting involved with Arikayce, which is inhaled amikacin. Next slide. Now, the therapies that we already have in our armamentarium, hypertonic saline, inhaled tobramycin, pulmozyme, azithromycin, and inhaled aztreonam, which is also called Caistin, have brought about significant improvements in lung function. And this is just a cartoon slide that I put together for last year's talk that show you kind of the average published improvements in lung function that we see with each of these agents. So on the ordinate or the vertical axis, we look at improvement in lung function as shown by FEV1. That's what we see on the spirometry. That's the number that we look at for airflow. And we see about a 5 to 10% improvement in airflow with any of these treatments. So those are already in our back pocket to use. In the last few years, we've also been involved in looking at some other newer agents. I told you about this modulation of airway surface fluid. And one study that generated a lot of excitement a couple of years ago was the Tiger series of studies, which is inhaled danufisol. And although the early study showed some promise and was published in a very good journal this past year, a follow-up study did not show that the danufisol resulted in significant improvement in lung function. And so that agent is no longer going to be developed. And you'll notice that when you check online, when we put the slides, if you go back to that therapeutic pipeline slide, you'll notice that danufisol is no longer in the therapeutic pipeline. An agent that I think we're going to be talking about a lot more next year is inhaled mannitol. And we've had some patients at our center involved in this study, and the early data looks quite good with this agent, and we'll probably be seeing a couple of publications on that this year. So I'm actually going to wait until next year to talk about inhaled mannitol. Upcoming trial opportunities, which I alluded to earlier, at our center we're going to be looking at inhaled levofloxacin, which is an agent that's similar to ciprofloxacin. It's going to be a twice-daily dosing regimen, and we're quite excited about looking at this agent. We think it's going to provide another opportunity for both our pediatric and adult patients. Arikayce, which I'm going to show a couple of slides on, is inhaled amikacin. And the nice thing about this agent is it looks like it could be potentially a once-daily dosing antibiotic. So this shows you what the Arikayce formulation is like. It's in a lipid bilayer, which we think in these liposomes, the drug is going to have a longer half-life. And we're hoping that later on this year we'll be gearing up to be involved in this study. It's actually coming through the Therapeutic Development Network, which is an arm of the CF Foundation. We've heard some early information about this study coming down the pike. Early studies with Arikayce have shown a significant improvement in FEV1, similar to what we see with Toby and with Caistin. In these early studies, we've also seen a reduced frequency of exacerbations, which is a key outcome measure that we look at in the CF population. There's a reduction in bacterial density in the sputum, namely Pseudomonas, and we also see improvements in quality of life, and that's a big one. For anybody doing a new therapy, you want to know that you're actually feeling better when you're using it. So that's an important outcome measure in most of these new studies. One of the things that I find particularly intriguing with this medication is that there's a potential for maybe being off this med for 2 months. So I'm going to shift gears a little bit here. I've been trying to think of a way to illustrate where we're trying to move with new therapies in CF. And I'm going to paint a little story here. This may or may not work. I've already put it through our editorial staff at home, and it's gone through a couple of revisions. But if we can go to the next slide, just picture yourself being the owner of a jewelry shop. So you've set up this really nice display window. You put a lot of work into having the ownership of the store and having everything being nicely displayed and having a wide range of opportunities for people coming in to buy things. And then hit the next slide. And then shortly after you set up the shop, the front window gets broken. And you're thinking to yourself, why did my store get hit? Why is it that now I can't put my nice jewelry out there because it's hard to get the insurance for all this? And so you've put maybe some smaller items in the store, and the window gets broken again the next week. So you put some bars up on the window. The bars are somewhat effective, but 3 weeks later, the store gets broken into again, and you're wondering, why is it that my store is getting broken into? Some of the other stores, they occasionally get break-ins, but they're not getting broken into as much as my store. So you put up some security cameras. And now the rate of break-ins to your place goes down, but it's still much higher than all the other stores on your street. So next slide. You get the police involved. So now when you get these big break-ins, you have an alarm system put in, the police come, and it really does knock down the burglaries quite a bit. But this is pretty cumbersome. You've now kind of messed up your front display of the store because you have bars in front of it and you've got alarm systems and whatnot. And then one day you kind of go out and you say, why is my store different from all the other stores? And you look down the street, next slide, and you notice that all the other stores have a nice bright light outside. So at nighttime, the burglars to stay away from there because the security cameras for those stores can show the burglar getting in. In your store, the light's burnt out. So the burglars just wait until nighttime, they break into the store. And even with all these security measures you put on, things just don't work out as well as you'd like. So the next slide is, we put in new lights. We put in a new light in front of your store. So maybe you still need to use all the other security systems, but it's much more effective now. And maybe you don't need to have the bars on your front window. You can still go back to having a nice display. And that's what I'm thinking of with these new therapies, is that we want them to be quicker, we want them to be more efficient, and maybe get back at the fundamental problem, which is people break into places when it's dark, right, when there's not enough light. So we want to restore that light. Similarly, in the CF airway, we want to restore the normal airway surface fluid, and the best way to get at that is to somehow repair the CFTR molecule, so that we're not having to come in after the fact with antibiotics and all sorts of anti-inflammatory agents, which are effective, but maybe not as effective as dealing with the original problem. So we're going to go through a fair amount of science today. I don't have a lot of time, so I'm going to try to put some cartoons in here so that it helps you understand some of the basic concepts. And I encourage you, once we get all this loaded on our website, I encourage you to come back and review these slides so that you really understand this. This is kind of like knowing how to fill out your taxes. There's some stuff that's a little bit, it's a little bit tough, but you got to do it. It's actually in your best interest to understand some of this information, because as clinical trials come down the pike, you're going to want to know, am I interested in being involved in this? So we're going to talk a little bit today about these correctors and potentiators. This is really what the whole Vertex story centers around, is we want to somehow correct the activity of the CFTR molecule. Next slide. So what is a corrector? Well, when we're looking at a mutation at the DNA level, it results in an abnormality of the protein. We're going to go into this in a little bit more detail in the next few slides, but when we talk about a corrector, we're trying to salvage the abnormal protein and get it to the surface of the cell so that it can do its job. In the most common mutation that we see in CF, the delta F508 mutation, most of the protein is recognized as abnormal and goes right into the lysosome, which is the garbage can of the cell. So it ends up destroying most of the CFTR so that it can't work. So correctors try to salvage the CFTR from this pathway, this garbage pathway. The other thing that we can try to do is for CFTR that does make it to the surface of the cell, there are other types of mutations that affect its activity. So sometimes it doesn't activate normally or signal properly. So we have a whole separate class of medications or compounds called potentiators, which can turn on the normal activity of this protein when it finally makes it to its proper destination. So the two key elements that we're looking at the molecular level, one is called transcription. That's when you start from the DNA and you transcribe it, or you copy it, to RNA, which is really the next template to make protein. And translation, you can see how complicated this is. There are a myriad number of controller proteins that regulate this whole process. But translation translates that code into proteins. And proteins are the things that do the real work in the body. Okay? So just imagine if you had a paint-by-number painting. Okay? And this is a beautiful painting of a bullfighter. And you have your paint-by-number painting, and it tells you which color to put in each little area. And you can imagine a transcription problem is if you ran your paint-by-number template through a copying machine and it just didn't copy well and you couldn't see any of the numbers, you wouldn't know, you wouldn't be able to translate that to the next step, which is what color do I need to put down. Okay? A translation problem would be if the numbers look to be okay, but you had the wrong paints and you're putting down the wrong colors. Look how it looks when you put down the wrong colors here. You end up with a completely different look. So these are the two issues that we're going to be looking at, transcription and translation. Now, why is this all so important? It would be really easy if everybody with CF had the same problem in their genes. If everybody had the delta F508 mutation, which is what we initially thought was the difficulty in CF, then we'd likely have one solution to the problem. But there are actually over 1,000 different mutations that we can see in CF that can cause disease. And some people have mutations that cause a very severe abnormality. This type 1 mutation causes an abnormality in transcription, so you never even make a full-length RNA. So these people tend to have very severe disease. And the most common type of mutation we see, the delta F508, falls under this class 2, which is you do get a full-length transcription, but there's a we have the colors wrong here. There's a color mismatch, and that's recognized as abnormal in the cell, and then that protein gets targeted for degradation. It goes into the trash can. So that's the delta F508 mutation. And then we have these milder mutations where the protein is made, it makes it up to the surface of the cell, but it just doesn't quite function properly. These are the class 3, 4, and 5 mutations. And I won't go through all the subtle differences between these, but it's important to know that in the Vertex trial that was published, the folks who were in that trial had this mutation, the G551D. That's a milder mutation. That's a mutation where there's a problem with the full expression of that protein. It makes it to the surface, but it doesn't activate normally. Okay, next slide. I want to go through a little bit more background on how to understand some of the data in this trial. We need to talk a little bit about the nasal potential difference. I bet all of you didn't know that we're batteries. I think I might have mentioned this before in previous talks, but we all have a charge across our nasal membranes. That battery charge is determined by the flow of salt and water across the nasal mucosa. Next slide. So this is actually a slide borrowed. I actually put this together from information from the Johns Hopkins website that goes over nasal potential difference. So if you want to really read about this in gross detail, you can go to their website. But I put up here on the left side, I put the normal scenario, and this is a normal battery. We have a C battery on this side, okay? And on the CF side, we have a 9-volt battery. And you might think, well, why did I put a 9-volt battery on the CF side? Turns out that patients with CF are highly charged. Did you know that? Your nasal membranes actually have much higher charge than on the normal situation. So if we look at the resting membrane potential in a normal nose, it's measured in millivolts. It's about negative 25. And in a CF patient, it's about negative 60. Okay, so there's a bigger charge difference. And the reason for that is that even though the CFTR channel is broken, the sodium channel in your nose is hyperactive. Okay, so that causes a big charge. So we have a negative 60 in the nasal mucosa of CF patients. Next slide. Now, when they do the nasal potential measurement, it's a sloppy test, but it's a very sophisticated test. They put 2 probes in the nose. One probe instills a bunch of fluid with various chemicals that we want to do for the rest of the test, and the other is an electrode that actually measures the voltage. And you have a reference electrode under the skin of the arm. So what we do in this next part of the test is we infuse a sodium channel blocker. And when we infuse the sodium channel blocker, the CF patients, the charge goes from negative 60 down to almost 0. So they have a big drop. Okay, and in the normal situation, it drops as well. We have blockage of sodium channels, but you see the difference is a lot smaller between the sodium channel blocker in the normal case and in the CF case. Next slide. What I've shown up here, this is a dead battery. No, that's bad. But so in the CF nose, after you block the sodium channels, you basically have a dead battery. So when you start infusing other chemicals to try to see voltage changes, you don't see any fluctuation. Whereas in the normal case, when we try to activate chloride transport, which can go through the CFTR channel, we see these nice fluctuations. Okay, these are very characteristic. First, we change the bath solution of chloride to drive chloride out of the cells, and in a normal situation, you can see this increase, and in the CF situation, it's entirely flat. And next slide. We still have our dead battery over here, and when we use an agonist or an activator of the CFTR channel called isoproterenol, in the normal situation you see an extra little hump, and in CF you see nothing. Okay, so I know this is a lot of science here that we need to show, but I need to at least give you that background so that we can understand some of the data that's presented in the New England Journal paper that I'm going to talk about in a couple of minutes. Next slide. So here's the New England Journal article that just came out in November 2010. This has made it into the newspapers. The CF Foundation has put out a lot of information about it. And we have a lot of scientists involved in this. We would have loved to have been involved in this study, but we really, first of all, don't do nasal potential difference measurements at Maine Medical Center yet. And also, we don't have a lot of patients with this particular gene mutation. Okay, but there will be opportunities for folks at our center to get involved in some upcoming studies. So what was done, this is actually from the New England Journal website. This study was done, believe it or not, with only 39 patients. And I have to emphasize again how important every one of you is. Every CF patient who's interested in doing research, how much you can bring to bear in the development of new medications, since we don't have a lot of people with each of these mutations. But they had 39 patients, and the study was done in two parts. One part, they had patients get an escalating dose of a compound called VX770, which is a potentiator. So that's the one that works at the top of the cell. All right. Potentiates activity of mutant CFTR. So they gave escalating doses in the first part of the study, and in the second part of the study, they used two high doses, and they studied it for 28 days, what the results were. So next slide. So again, a busy slide, but now you're all experts in nasal potential difference, right? I've given you a little bit of help on the right side of the slide. I'm just showing you the direction of where better is. Okay? So what they looked at in this study is, remember that difference after we blocked the sodium channels and things became flat? We really want to see some change when we put the activators in. So what this slide is showing you is the change in millivolts. So if there's no change, you stay right on the dotted line. Okay? Go back a slide again. So no change is right on the dotted line. This is the first part of the study, which is the 14-day trial, and they used escalating doses of VX770. And as you notice, when we go up on the dose, there's an increase in the fluctuation of that signal, which is a good thing. That's what you want to see. All right. On the other side of the slide is showing the second part of the study, where they used a higher dose, which is 150 milligrams or 250 milligrams. We see a similar effect, where after 14 days and 28 days, there's a change off of that baseline. And you might say, wow, these are really tiny changes. They're actually very significant changes. If we see a change in just a couple of millivolts, that's a real change. I'll show you in the next slide. We have actual additional proof of this. Now, this medication is not given as an inhaled medication. This is systemic therapy. Patients took a pill. So, if this pill is going into the body and going throughout the body, it should affect other places beside the lung, like the sweat gland. And in fact, when you measure the sweat chloride in patients with CF, it tends to be very high. What we see is with the Vertex, it comes down very nicely. And this dotted line here at 60, in the adult population, that's the cutoff for normal, the lowest end of normal. So you can actually see that at 7 days and 14 days, we have patients who are actually moving into the normal range with their sweat chloride test. And this is the reason there's so much excitement about it. Is this is really the first evidence in this type of study, a large randomized study, that we're seeing that degree of change in the sweat chloride test. It's showing the activation of the CFTR, a highly specific response. And here we see again, in the second part of the study, we have a sustained response for 28 days. So again, many of these patients, and these are shown as group data up here, and each of these dots is an individual patient down below. So you can see the scatter of it, but these are really dramatic changes. Everybody's very excited about that. Now, as Hebe mentioned earlier, you have data and then you have information. What most patients with CF are interested in, they're not so much interested in sweat chloride tests and nasal potential difference. They want to know, what's my lung function? And rather surprisingly, we see that there's an improvement, even in the short interval. I never would have expected this. And in such a short interval to see an improvement in lung function on the order of what we see with inhaled tobramycin and pomazyme. Okay, the relative predicted change, about 10% improvement over that short period of time. And you can hypothesize why that might be. Maybe we're opening up mucus plugs or something like that. We still don't totally understand this response. But again, on this graph, we want to see up as better. Okay, next slide. So the conclusions that we can gain from this study, this is a small study, only 39 patients, is that the medication is safe. There was a very good adverse event profile. I don't have the time to go through all that, but you can get that from the New England Journal article. This was associated with what they call within subject improvements. That means that they used each subject and they followed them over time and said, we're not just comparing you to somebody else, we're comparing you to your baseline. So these patients actually showed improvement in both the activity of the CFTR as measured by these electrical and sweat chloride measurements, and also in lung function. And these findings support further studies with potentiators of CFTR. In addition, it shows what we call a proof of concept, that there's a way of potentially repairing the activity of the CFTR at a very fundamental level. Now, how do we even find these compounds? I've shown this slide in the past, but to me this is a fantastic story that's worth repeating. There are several groups that are screening large libraries of compounds. So we don't know where the next discovery is going to come, but the way they're doing it is really on an industrial approach, where we now, because we've been able to clone the CFTR channel, we can use a colorimetric assay to see whether it's working. Basically, you can look at these plates and see whether they light up properly or not. Each well, you can see whether it lights up with the rate of change of the lighting. And go to the next slide. These can all be put into a robotic system where you can find lead compounds that look like they show promise. So you see a little flashing light, you say what compound went into that well, and then they can make a whole bunch of derivatives of each of these potential lead compounds and bring them into the clinical arena. So which compounds has Vertex developed? Well, we have one, VX770, which I just talked about, and that's a corrector. And so on the face of it, we would think that it would work best for those type 3 mutations like the G551D. The protein makes it to the surface of the cell, but it doesn't activate normally, and this works as a potentiator. It activates those proteins at the surface. And in fact, we have 2 phase 3 clinical trials that have involved pediatric patients and adult patients with G551D, and as Stacy mentioned earlier, there look to be positive results in both of those patient populations. Now, there are some folks who are interested in looking at whether this chemical, even though on the face of it, it may not seem like it would work for the delta F508, we know in the lab that a tiny amount of delta F508 does in fact make it to the surface of the cell. So we want to know, does the VX770 activate delta F508? And so there's a clinical trial that's ongoing now with that. We don't have all the data to present on that yet.
Phase 2 and phase 3 again are?
So phase 2 is the early dose ranging studies, and phase 3 is, I actually don't, we went over that a year or two ago, but if anybody's interested, I can go through that. I just want to make sure I don't fall too far behind. So corrector, we do have a corrector molecule, VX809. VX809 is now ready for investigation, and we're hoping at some point that we'll be able to get involved in one of these studies. The next slide. It's actually being studied in combination with VX770 using a cocktail, and this may be what's necessary for some patients with delta F508 mutations. You may need a combination of a corrector and a potentiator. So that's in phase 2 study right now. And VX661, I really don't know a lot about this, except that you can see that there's a little bit of information on the Vertex website. Again, another corrector, and it may turn out that certain correctors work better for certain mutations than other mutations. Excuse me. So I'm going to finish up a little bit early here. You are the key. I can't emphasize enough how important it is for every patient to consider whether a potential study would be right for them. And our job as the CF care team, as well as the investigators, is to kind of see which clinical trials would be best for our patient population. We want to utilize our resources the best we can so that we can bring the types of studies that would be most desirable to all of you and hopefully move the field forward. I did want to put in a pitch for another website. I know a lot of you are web-enabled. There's a Northern New England website which also has the videos for the CF Education Day. It also has some information about the research that we're doing as a group. So you can see some of the posters that we've presented at national meetings. With that, I'll close and open it up for questions. Not too bad. Hi, Doug.
The VX809,
Yeah.
under the best case scenario, if that was a successful new drug, how long is that going to take to get from testing it, trials, FDA, everything that's got to go through to actually get to someone that needs it?
It's a great question because a lot of this has to do with there's a numbers game. There's also for agents that are like the inhaled antibiotics. Sometimes those take a little bit longer because you already have an agent with a similar activity that's out there. So you not only have to show that it's effective, but you have to show maybe that it's not inferior to something that's already available. With the more novel compounds, that route may be, it could be longer or it could be shorter. I think that there's, and Stacy may be able to, is Stacy still here? No. She may be able to speak a little bit about VX770. I've heard whispers that they're trying to get something that's available for the FDA to approve by 2012, which would be really pretty quick given the small numbers that we have in this initial study. But it's being looked at in a larger pool of patients who are Delta F508 homozygotes, and that may be one of the ways that they can get it through the FDA more quickly, especially if we see positive results in that population. Yes, Aura?
I was just wondering, when you were talking about you said about 1,000 different mutations, right? So when you're talking about these compounds, I mean, is it reasonable to think that those possibly could be helpful with all those, or really could be that each of those mutations would be a totally different compound? You just don't know that?
Yeah, you may. That's a great question. So the question is, since there are over 1,000 different mutations, are we going to need more than 1,000 different medications? The good news is, I always try to put some good news in this, is that you only need one working copy of the CFTR to normalize the physiology. So just as a nature's experiment, people who are carriers who have one broken copy, they have no symptoms at all. So if we can find, most people who have an unusual mutation, it's paired with a common mutation. So if we can fix one of the common mutations, then you probably don't need to repair the other one. That's why people are focusing so much on Delta F508. Exactly. Yeah. Thank you very much. Oh, one more question.
I'm just plugging in the computer.
Okay.
Sorry,
Yeah.
I do have a question. When identifying patients for trials or studies, I mean, it's good for us to be aware of what studies are going on and whether or not the patient has the type of mutation that might allow them to participate. But on the other end of that, does the clinic identify by patient what studies are currently being, looked at, and do they talk to the patient specifically, proactively about participating in them?
Excellent question. I'm repeating these questions just because we're recording a lot of this. So the question is, patients should be, and correct me if I'm wrong on this, patients should be aware of what studies are out there, but is the clinic also screening to look on a patient-by-patient basis who might qualify for various studies? We do that. That we actually have, and Hebe's actually been quite instrumental in developing some of the tools on Port CF. One of the tools on Port CF enables us to screen our patients based on the criteria for the different studies and run a query, and then we can see who qualifies. And obviously, out of that pool of people who qualify, not all of them would either be interested or would truly qualify based on their total picture. But it does give us that information, and it's been invaluable for us to get things moving quickly for our trials. I should mention that the process of getting people into clinical trials is highly competitive. So some of the sponsors may determine that they need 250 patients, and they may have 50 or 100 centers involved. Okay, so if we say, all right, maybe we might have 5 patients who would be interested, but it takes us 6 months to ask them and get them enrolled, we may only have an opportunity to get 1 or 2. And that actually happened to us on one of the Vertex trials. We only got 1 patient in because it was filled up by the time we were ready to go. So using these query tools and being proactive, I think, is going to be very important for us maximizing our involvement. Good question. Thanks.
Good. Thank you, Jonathan. That was very, very exciting.